Good afternoon, everyone. Welcome to KPQC Learning Forum for February. I hope you're all doing well. I'm going to go ahead and hit record and going to let people come on in, and I will turn it over to Tara and Carrie to get us started.
Hi, everybody. Happy Tuesday. If you haven't already, make sure that you put your name and your agency in the chat, please. And you can do that throughout the entire Learning Forum. We typically don't use the chat very often during this time because we want to make sure that we're good students and listening to the teacher, but also because if there's a lot of offline conversation, it interrupts the conversation of education. Having said that, absolutely important, and you'll see their contact information, but Stephanie and Sarah are very, very interested in questions that you might have. So we're going to try to give them some time at the end. Carrie and I will also talk about some open-ended sessions that we're going to host coming up. So we definitely want to talk to you all and connect as soon as possible. Next slide, please. So speaking of our next office hours, that really is just an open session of about an hour where Carrie and I are available to answer questions from the champions. If you have colleagues that are working as part of your fourth trimester work at your hospital or facility and they have questions, absolutely they're welcome to join. But we leave it open-ended with a little bit of an addition of sharing that PowerPoint that we're going to talk about in a minute, the kind of end-all, be-all fourth trimester slide deck that we shared out. We touch on a couple of those pieces so that it makes sense, and then wrap that into questions and answer session from you all. So please join us this Friday at noon. If you have not received a link, reach out to Tiffany or to Carrie or I, and we're happy to make sure that you have that. Next slide. So since we've started this project nearly 2.5 years ago plus, it's been important for all of us, including the KPQC membership, that we share information and resources. We use that to utmost benefit during COVID, and I like that it continues to this day. An article that you see referenced here as part of what we now call rapid response is the idea of getting information out to as many people through our KPQC work, to include inpatient labor and delivery updated protocols, outpatient protocols and guidelines, things that would help all of us to be better, smarter, more safe providers across the board. And this is an example of a massive or major update that came through from ACOG in January, so just last month. Significant changes in the definition, identification, diagnosis, and quote treatment of first and second stage labor. If you have not read this article or heard conversation of this article, I'd be kind of surprised. It definitely was a buzz before it came out officially, but certainly since January, our hospital included, lots of conversation about the definition of active labor, when patients are admitted, what constitutes a restive phase, et cetera. So bottom line, read the article, share it out. At our labor and delivery unit, we just sent it around, made sure everybody has read it. Great information coming from ACOG. Next slide, please. Dr. Bettinger is an important piece of our KPQC. She has been for many years, and she does a great job of making sure that I get a nudge and we get a nudge on the infant and newborn side. She sent this to us actually back, I think, in December, but some alarming news that came through in November of last year, November 2023, that said, hey guys, I know you're all talking about maternal morbidity, mortality, but can we stop and pay attention to infant mortality rates? And as unfortunately expected, we have seen a significant rise in the United States infant mortality rate. Now, what does that mean for Kansas? And our epidemiologist, with a nod to Sarah, who's getting ready to talk, would tell us to take caution in that moment. Really, really read through what the data shows, make sure that it's accurate and not overblown or under reported, and look at the Kansas specific data. And so to the right, I'm not going to walk through this, it will come out in your slide deck, but I pulled the 2022 vital statistics from Kansas, which talks specifically about causes of death in the stillbirth realm. I would encourage you all to look at that and to see what some of those themes are that are coming through. Again, I'm setting up Stephanie and Sarah's conversation because there is some significant correlated outcome problems And as we all know, infant morbidity and mortality stems from oftentimes maternal morbidity and mortality. And so again, we'll deep dive today, but an alarming concern, a nod to our pediatric groups that are working so hard in our hospitals and outpatient realms to help. But we got to pay attention here, folks. Next slide. Quick follow-up to our January Learning Forum, and I know Carrie got lots of feedback as well as I did. You guys immediately jumped in to this conversation of the triage question. And next slide, please. Ta-da, ACOG agreed. So ACOG put out this phenomenal, I'm going to call it a bundle, but it was a really great free shareable bundle of really using resources, specific protocols, and how to help obstetric emergencies and non-obstetric settings. So not just emergency departments, but to include emergency departments. That link will be provided to you all. Again, I'd encourage you to share this out with your urgent cares, your walk-in clinics, certainly in your EDs, some really helpful tools for them to use in the conversation of, are you currently pregnant or have you been pregnant in the last year? Boom, there's your protocols and your help to all your ED partners. Next slide. Again, keeping in line with keeping everyone updated on what's going on in Kansas with all the important maternal and infant education pieces. Kansas Breastfeeding Coalition, High Five, and certainly KDHE have teamed up and included the first trimester work, but more globally, KPQC membership to invite them to these hospital lactation skills fairs. If you use the QR code right there, it links you directly into registration. As you can see there on the left, there are 4 dates. When you go into the registration link, you can sign up for those dates, noting that the April 2nd afternoon session is booked already. Great problem there. But we encourage everyone to make sure that you go or send folks from your facilities to one of these skills fairs. If you have any questions, reach out to Brenda Bandy directly. And again, all that information is on that registration when you click through. And I think Brenda just put it in the chat for us too. Next slide. This is just another nod to that earlier slide. I think I just mismanaged my slide deck. But again, just so that you all know, once you click through on that obstetric emergencies ACOG bundle, you get lots and lots of great stuff, including posters and signs. And that sign, you see the picture on the left with the 3 women, and certainly one pregnant, one with baby. This is one example of a poster, free printing PDF version that you can put in your emergency department tomorrow. Outpatient clinics, we encourage it at our family practice offices as well. But again, great information when you just see it. Next slide. So as we move into the conversation of 2024 and a nod to all the hard work that's happening, I think Carrie and I and Jill feel very strongly that we have to stop again and tell you all how impressed we are by your work. You're in the weeds, you're doing all the hard work, but I need you all to know that when we calculate how many families, women are impacted by the work that you're doing, the birthing people in Kansas are now 31,000 strong with getting a massive change in their postpartum care. It's 93% of births that are happening in our state are now better because of the work of the First Trimester Initiative, and a hats off to you all. We'd like it to be higher, right? We want 95, we want 99, we want 100, but that's impressive considering we started out at 0. Next slide. Go ahead and hit the next slide for me, Tiffany. So when we look at what you all can do next, and we talk about specifics here in a minute, I also want to bring to your attention what I talked about earlier, which is the Kansas Vital Statistics data and the reports. This is my nerd out moment every year when these data sets come out in this very large report, and it may mean nothing to you all at the local level because it's so cumbersome, but I'd encourage you to do it. I click on the link, go to your county first, look at birth rates, death rates, look at the summary information at the first few pages, and you get a snapshot of what's happening in Kansas, but you get information about your county. Those of you that are serving patients for many counties, perhaps you're a tertiary care center or you're in a remote area of Kansas, and many people are coming to you because of the OB deserts happening across the state. you might want to look outside of your county and see what the data shows. It's wonderfully helpful. It gives you a feedback if what you're hearing or seeing at the bedside is actually true, and it tells us where to focus in our efforts. Those of you that are smart, high level, is going to see that 2022 obviously is over a year behind. That's not uncommon. KDHE is working really hard to get everything caught up, but we got a little bit behind with COVID and data reporting. So excited to see that information. We will use it throughout the year to push conversation forward, but I'd encourage you to take pause and take a look at that. Next slide. Again, I've just pulled out specifics. You're going to see it in the slide deck. I always find it interesting, that left-hand side that says every day in Kansas during 2022, how many births typically occur, how many deaths typically occur. Please note that those numbers are not that different. And then on the right-hand side, when we talk about vital events and percentage of change in a 3-year time frame. Actually, yeah. But look, 2003, 21, 22 snapshots. Wow. Right? Wow. Look at what's happening. Look at the change. Some of it's uncomfortable to read. But again, this is why we do the work. Next slide. More data, and this is hard to read. Sorry, you guys. But again, take a look at it when you come through. I pulled out racial demographics, the differences in birth statistics and rates coming from different birth weights of infants. I pulled through prenatal care in first trimester, how we're doing based on racial demographics. And then on the left-hand side, just the overall look in terms of breakdown of racial demographics in Kansas for total births in Kansas. Again, when we look at who we're serving and who we're caring for, pay attention to what's going on. Next slide. PRAMS. Stephanie would agree that PRAMS gives us some really valuable data. And the reason it does is because it's patient response directly to surveying. And so again, just pulled out the story that I think you all know. Vaping is a problem. Vaping is a massive problem, and vaping is not reported on birth certificates specifically. And so one of the things I'm watching on my side is, what is the data showing us on nicotine use? What is the vaping criteria? What are patients reporting to us in PRAMS data? And are we asking and helping with this potential connection to adverse outcomes in our state? So food for thought, and another data set that we pull from. Next slide, please. And I'm actually going to let Carrie take over one slide ahead of what I told her she would. But Carrie, obviously we're sending out report cards for every hospital to the champion. You want to tell them how that's going and then walk them through those next two outcomes?
Yes, and for those of you who have taken the time to look at your report cards and get back to me and let me know that things need to be corrected, I really appreciated that. We had some issues with our Excel spreadsheet and the macros built in with that, and they've all been fixed. So I encourage you all to take a peek, make sure that it's a true depiction of what the work being done at your facility is showing. And then just know that the flower is great to give us a nice visual, but really the table on the second page is there to let you know what each initiative is, whether it's an AIM data collected specific initiative or a Kansas specific initiative, and then how it's being reported in QHI with a little description by that. So that's really, I call it the key or the legend to help you understand more of what each piece of the bundle is. As you can tell just from the image in itself, hats off to you, like Tara said earlier, huge bundle that we've taken on, you've taken on, and you're doing a phenomenal job. So next slide, please. Okay, what we have here is just some graphs that we broke out from the data we've collected from all of the facilities enrolled, excuse me, in the FTI. And what I want to be able to highlight here is, again, the nod to all of you and the work that you're doing. As you can see, in December of 2021, just with our community resource list, the abundance of green we have, which means not started yet on a particular project or not enrolled. The red is the facilities that were not enrolled yet within our program, versus February of 2024, that's the yellow is all those that have fully completed that. So I love to break these down, again, a visual person, and just be able to see over the time how we've changed, how we've onboarded more facilities throughout the state, and then tackled each task. You'll see that with the post-birth training and embedding that in your discharge planning, as well as, next slide, please. The making sure that we're scheduling our postpartum appointments and ensuring that our patients are cared for by a well-rounded postpartum care team within the facility as well. So I think it's a great resource for us to be able to look at and identify how far we've come, how far we still have to go as we close out this initiative this year, but really for you guys to see the opportunity to give yourselves a pat on the back, because throughout the state, we're doing a really, really good job. Next slide, please.
Yep, so I'll jump back in. Yeah, I like the point, Carrie. That's helpful. So you all, and I just got a question from Shannon in the chat about if we didn't get a report card, what do we do? Absolutely reach out to Carrie. She is report card queen. We could come up with lots of names for that. But she is certainly in charge of that piece, and I'd encourage you to reach out if you did not receive your report card. Also, nudge from me if you did not receive the what we call the final planning PowerPoint slide deck. You see little screenshots underneath there of that very large PowerPoint, which really, you guys, walks you through every single point of the fourth trimester again. For those of you that have been doing this for almost 3 years, and you just saw your work, you saw that many of you now are in the yellow category, so that you have completed almost all of these benchmarks. For some of you that are brand new, you're going, I don't even know where to start. I don't understand all of this. And this PowerPoint serves both of those continuums. Those of you that are just making sure that you have everything set up so that we're getting completed in 2024 with all of it with fourth trimester, and those of you that are fairly new, everybody in between. Each benchmark is outlined in that PowerPoint. If you did not receive it from me, reach out to me directly and happy to send it again. Next slide. And for everybody across the state, most especially our fourth trimester sites, but quite frankly, we need everybody on the same postpartum model in Kansas. This is the fourth trimester project in a visual. From left to right, what happens at the birthing facility, at the home, wherever the birthing person births. All of those things are standardized, they're educated, there's standardization of what's said next and done next, which is referral to outpatient care based on screening, appropriate appointments and referrals made, and then they attend their comprehensive postpartum visit. Underlying all of that, you see underneath it is a postpartum care team. Who does the patient need to walk from left to right with a positive outcome, both in terms of health, but also mental health, follow through, community support, etc. This is the model. Next slide. And again, I needed you all to remember March 1st, that noon. You all should have gotten a Zoom link, like I said, if you are a champion. If you didn't, reach out to Tiffany for me. But certainly we'll answer questions at that time regarding that new postpartum care model or questions that you may have at your site. Next slide. Birth equity training. Many of you have started birth equity, have completed birth equity through Kansas Birth Equity Network, KBIN, or are getting ready to start. There are 2 cohorts left, you guys, early March cohort, and then an April cohort, and then we're done with KBIN. So if you have questions about birth equity training regarding KBIN training, you need to reach out to me ASAP. We're running out of registrations. And for those of you that are going and have questions, I've already reached out to you, but don't hesitate to nudge me and say, hey, Tara, here's some concerns or questions we have moving forward. In front of you are the 6 modules that are part of that phenomenal training through KBIN. And we're so excited that many more of you are in the process of getting trained up across the state. Next slide. The second part of that, of course, is our statewide training we're doing, specifically with Mama's Voices. The 3 dates in front of you, March 19th, April 16th, and May 1st, will be the online webinars. That's the same content repeated 3 times. Again, those links are provided to the champions and then sent out from champions to your staff members that you want to attend. There's no limit to who can attend, and it is free. We will be talking about birth equity, honing in on an action plan, and making sure we talk about the patient debriefs benchmark that's mentioned in our bundle. How do you include the patient who is a part of an adverse outcome at that debrief moment? So we'll be seeing you March 19th. We'll be nudging you before that, but 3 dates, repeat performances, and certainly we hope to see all of you there. Next slide. Whew, Stephanie and Sarah, I cut into your time. We're going to go fast here. You guys, we heard about this presentation from Jill. Jill keeps saying, we got to do this, we got to do this, and we do. And looking through what's ahead, you all are going to be a little shocked, a little uncomfortable, and very much more knowledgeable about some adverse outcomes that we noted these two women called attention to, and now we're taking this information across the state. I'm not going to read you their bios. I want them to introduce themselves, but Stephanie and Sarah, welcome. Please introduce yourselves and let's get this party started to tell them some really helpful knowledge about maternal and infant outcomes in Kansas.
Sorry for that. It took me a moment to get across my monitors to the right one to unmute. So good afternoon. On behalf of Sarah and myself, I'd like to thank you for giving us this opportunity.
I think Stephanie's frozen. And-
She is. I can't see or hear anything either. Tara, are you frozen too?
Can you all hear me?
Oh,
Is my
there you are, Stephanie. I can
I'm
see you
back
now.
on. Was that
Okay.
me?
Yep, you froze.
Huh. All right. Hopefully that doesn't happen again. My apologies. Yeah, just wrapping up, a big part of our charge is to get resources in the hands of you all as clinical providers, as well as our public health folks, and hopefully kind of bridge the gap and help to facilitate partnerships between them. Next slide. I won't take time to go over these learning objectives in detail, but in general, we hope that a couple of the key findings and takeaways will resonate with you, and that you will be able to identify an opportunity that you have to impact COVID-19 infection rates and outcomes among the perinatal persons you serve. And at this point, I will hand it over to Sarah and let her introduce herself.
Thanks, Stephanie. My name is Sarah Cichelli, and I am an epidemiologist with the KDHE Infectious Disease Epi section. And I've been doing some work with COVID-19 during pregnancy throughout the pandemic. So here, I just wanted to talk about an analysis that we did of outcomes related to maternal COVID-19 infection during pregnancy. Next slide. So with this analysis, we primarily wanted to know whether COVID-19 infection during pregnancy impacts certain pregnancy and infant-related outcomes. To answer this question, we structured the study to examine maternal COVID-19 infection during pregnancy as our exposure of interest and several different outcomes of interest, which we grouped into 3 sections: pregnancy-based, infant-based, and stillbirth outcomes. The comparison or non-exposure groups for each of these sections would be all pregnancies among Kansas residents without documented COVID-19 infection, where the infants were born or stillborn within the same date range as the COVID-19 pregnancy group. We also wanted to be able to describe COVID-19 vaccine uptake among women with COVID during pregnancy, as well as among women of reproductive age in Kansas, though we could not directly compare the 2 groups. Next slide. We conducted surveillance to identify all COVID pregnancies among Kansas residents, pulled a random sample of those pregnancies, and collected data on each sampled pregnancy, primarily through medical records abstraction. When identifying COVID-19 pregnancies, only those among Kansas residents with PCR confirmed COVID infection occurring during the calendar years 2020 and 2021 were included. After records with missing data were removed, our overall sample sizes turned out to be 1,089 pregnancies and 1,097 infants born from those pregnancies. However, there were some demographic differences between records with missing data and those that were included in our sample, which suggests that our sample may not be truly representative of all pregnant people in Kansas due to the potential for sampling bias. Next slide, please. We did stratify our sample of COVID pregnancies into 3 age groups as depicted in this table. We then matched our sample group of COVID pregnancies with the statewide comparison group of non-COVID pregnancies on a 1:10 ratio for each age group. The middle age group of 25 through 34 years of age contained far more individuals than the other 2 age groups, which may have influenced some of our statistical results. Next slide, please. So now that we've got an idea of how the analysis was set up, we'll get into some of the results here. And first, we'll talk about some of the pregnancy-based outcomes that we studied. We found that regardless of age group, women who were infected with COVID-19 during pregnancy were about 50% more likely to have preeclampsia or gestational hypertension compared with women who were not infected with COVID during pregnancy. Similarly, we also found that women who were infected during pregnancy were about 40% more likely to have gestational diabetes, regardless of age group. For both of these outcomes, the statistics support the idea that COVID during pregnancy is associated with these health outcomes. However, because we weren't able to assess that these health outcomes happened before or after COVID infection, we can't say that COVID infection during pregnancy caused an increased risk of these health outcomes, only that it's associated with an increased risk. So something to note there. Next slide, please. For our other pregnancy-based outcomes, significant associations, if any, were found among only 1 or 2 of the 3 age groups at a time. These could reflect true associations or merely be an effect of the difference in age group sizes. Unfortunately, there's no way we can really know for sure without further analysis. So for now, we have to be extra cautious when drawing conclusions based on these results. Maternal ethnicity would be an example of this phenomenon, since we only saw an association among the middle age group, and women in this age group who had COVID during pregnancy were about 25% less likely to be Hispanic or Latina compared to those who were not infected. We also found no significant association between COVID in pregnancy and maternal race, regardless of age group, which I thought was interesting. Next slide, please. When looking at county type or level of urbanicity, we again found an association only among that 25 through 34 age group. Those infected with COVID during pregnancy were about 20% more likely to live in a rural county as opposed to a more urban county when compared to that same age group among those who were not infected. If found to be a true association, this might have been influenced by various factors such as vaccine uptake and attitudes towards COVID prevention measures among some of those more rural communities here in Kansas. Moving on to maternal insurance status, we found an association only among the 2 oldest age groups. Women who were at least 25 years old who were infected during pregnancy were about 60% more likely to have health insurance compared with their non-infected peers. If found to be a true association, a possible explanation for this might be that those with health insurance had better access to testing or were more likely to test. Next slide, please. We also wanted to look at maternal education level and level of prenatal care received, but unfortunately we had to exclude these outcomes from our analysis due to too many missing values in our COVID pregnancy data set. This information was not typically accessible or able to be calculated from the medical records or birth certificate data that we had access to, and ended up being missing for the majority of our sample, such that we cannot compare with the non-COVID group, at least with any sort of validity. We were only able to determine education and prenatal care levels for 12 and 30% of our sample, respectively. Next slide, please. So now we'll switch gears a little bit and focus more on those infant-based outcomes that we studied between our COVID pregnancies and our non-COVID pregnancy group. These outcomes include birth route, preterm birth, birth weight, and whether the infant was breastfed. We even looked at breastfeeding specifically among mothers who were infected with COVID within 14 days leading up to delivery, since we surmised that that might be a more relevant grouping. For birth weight, we looked at whether the infant was considered low birth weight or less than 2,000 grams, as well as the actual numerical value of the birth weight. However, for each of these outcomes, we found no statistically significant association with maternal COVID infection during pregnancy, regardless of age group. With the exception of the low birth weight status, where COVID infection seemed to have a slight protective effect, each of these outcomes did have a weak association with COVID-19 pregnancy in the expected direction, but were just not statistically significant. This could be due to sample sizes and power, as I've mentioned before, but we can't know for sure without further study, unfortunately. These findings were surprising to us because we would have expected there to be a stronger statistically significant association supported by existing literature for these outcomes. Further, the direction of that association with the low birth weight status was the opposite of what we would have expected. Though again, this was not a statistically significant effect. Next slide, please. The results for gestational age were especially surprising, given that existing literature supports a significant association between COVID in pregnancy and preterm birth. So we decided to look at gestational age as a numerical outcome rather than categories. Yes, no, was the infant preterm? And to see if we were missing anything by oversimplification. We looked at the average values for gestational age and compared the means among the COVID pregnancy group with that of the non-COVID pregnancy group for each age group. We found that the mean gestational age at birth was significantly lower among infants born to mothers who were infected with COVID, but only among the older two maternal age groups. This, again, could be an effect of age group sample sizes. And also it's worth mentioning that the difference in mean gestational age between the COVID and non-COVID groups was only 0.1 weeks. So although it may be significant on paper, it's not really significant in practice, and additional analysis would be needed to explore this relationship further. Next slide, please. The next outcome we analyzed was stillbirths. We wanted to know whether COVID-19 infection during pregnancy impacts the likelihood of a stillbirth occurring. And here we did find a significant association between COVID during pregnancy and stillbirth, but only among the two youngest age groups. Women who were less than 35 years old and had COVID while pregnant were almost 3 times as likely to experience a stillbirth when compared to their non-infected peers. I will note that in that 35 and older age group, we did find a similar effect, though the result was not quite statistically significant. Next slide, please. Moving on, we'll get into some of the COVID-19 vaccine data that we had. And unfortunately, statewide vaccination data does not capture pregnancy status, and our comparison group pregnancy data did not capture vaccination status. So there was no way for us to compare vaccination rates specifically among pregnant people only. We did get vaccine data among women of reproductive age in the state, so we at least have a similar group to look at beyond our COVID-19 pregnancy group. However, with these two populations being different enough, we cannot directly compare or perform any statistical analyses here, though we can at least look at a descriptive breakdown. So here, with these charts, we have COVID-19 primary vaccine series completion in both our infected pregnancy group on the left and our statewide population of women of reproductive age, which is on the right. Again, these are not directly comparable, but you can see in our COVID pregnancy group that the vast majority did not receive any COVID-19 vaccine during the study period. Next slide, please. So now we'll shift a little bit and look only at our COVID-19 pregnancy group, where we were able to describe the number of doses received among those who received at least one COVID vaccine, as well as the timing of all COVID vaccine doses received relative to clinically important time points. There were 288 pregnant people from our study who received a COVID-19 vaccine, and there were 583 doses administered among those 288 individuals. The majority of these individuals received 2 doses, and the slight majority of all doses received were administered after delivery. We can't make any conclusions off of this data alone, though it may help support additional data on attitudes and behaviors surrounding COVID vaccination during pregnancy. So this slide sums up the most notable and relevant findings for you. So if there's anything you take away from this analysis, it would be these points. Pregnant persons infected with COVID were nearly 3 times as likely to experience a stillbirth when compared to non-infected pregnant persons in the state. Regardless of age, pregnant persons with COVID were significantly more likely to be diagnosed with gestational diabetes, gestational hypertension, or preeclampsia when compared to non-infected pregnant persons. Possible associations may exist between prenatal COVID infection and maternal ethnicity, county type or urbanicity level, health insurance status, and gestational age, though more data would be needed to further evaluate these relationships. Overall, there was no significant association found between prenatal COVID infection and birth weight, preterm birth, maternal race, and breastfeeding. These findings, other than the breastfeeding outcome, are inconsistent with existing literature. Generally, there was also poor vaccine uptake in the COVID-19 pregnancy group during the study period, and over half of vaccine doses received within this group were administered after delivery. More data is needed in order to evaluate the attitudes and beliefs surrounding COVID-19 vaccination within the context of pregnancy and perinatal populations. Next slide. Oh, I'm sorry, I forgot to do next slide for the last one. This is the slide that I just spoke about, so you can review at your leisure. Next slide, please. So sorry about that. I would like to briefly mention the limitations of this analysis, which were quite a few. The most notable ones we encountered were surveillance of the COVID pregnancies being limited by pregnant people's access to testing, inconsistent or missing data leading to significant differences between the included population and the excluded population due to that. And more information is needed on these differences to better understand generalizability of the results. We did also have a limited capacity for data collection and therefore smaller than ideal sample sizes, especially after stratifying by maternal age group. And lastly, we couldn't compare our different groups of vaccine data due to our specific data sources. So we are again unable to generalize our findings to larger populations. Next slide. And here's some helpful resources if you would like to further explore the topic of COVID-19 infection related to pregnancy. There is quite a bit out there. And then next slide. And so the next, this slide and the next 3 slides, I just have included some supplemental tables that include descriptions of the outcome variables we described, as well as a summary of our statistical measures. And then can you skip ahead to the last slide, please? The acknowledgement slide. Thank you. And I've said it before and I'll say it again, it takes a village to run a data analysis, especially during COVID. So I'd like to give a quick shout out to everyone who lent their time and expertise with this study. And that's all from me for now. I will let Stephanie take it away from here. Thanks all.
Thank you so much, Sarah. I don't know, it seems I'm having trouble with the video switching over to me. I'm not sure what that's about. Sorry, Sarah, you may be staying on camera here while I present. I had IT working on my laptop just before the presentation, so apparently there is a glitch, so my apologies. In this section of the presentation, we'll talk about how COVID-19 infection impacted a subset of pregnant persons in Kansas who participated in a specific prenatal education course that is offered throughout the state. So kind of drilling down from Sarah's data, that was kind of a look at the state as a whole. We're going to drill down into a specific subset. We will also discuss these participants' vaccination rates and their reasons for not getting vaccinated against COVID-19. I would like to recognize Brandy Markert, our MCH advanced epidemiologist, for her cleaning and analysis of the BAM program data, which I'm about to present. So this slide provides a little context about the prenatal education course known as Becoming a Mom, or BAM. Some of you may have heard of it or be familiar with it. It's offered in 20 communities across the state through the KPCC model. It's provided through a collaborative model between public health and clinical care facilities where pregnant persons have access to this free prenatal education course, providing standardized evidence-informed information. I will just make mention that in 2022, participant numbers were still low due to the continued impact from the pandemic. So you'll see the total number here of 542 participants is significantly lower than a typical year's number of participants. Next slide. This map shows the number of prenatal education course participants that completed the course at each site. It should be noted that the participants were not evenly distributed across the state. For instance, relatively few participants received the course in the western part of the state. Meanwhile, more than 1/3 attended the course at Sedgwick County site. And again, keep in mind, this is 2022 data. Fortunately, we do have higher numbers in some of these locations at this point. Next slide. Participants ranged in age from 15 to 45 years old, with the median being 27. The course reached a racially and ethnically diverse population, with around 1/4 of participants being of Hispanic ethnicity. About 8% of participants were of non-Hispanic Black race and ethnicity. Additionally, about 12% of participants were primarily Spanish-speaking. Next slide. Around 1 in 8 participants, or 13%, reported that they began the course, or that when they began the course, they had COVID-19 sometime prior to pregnancy. During pregnancy, around 1 in 20 participants, or about 5%, reported developing COVID-19 infection. Due to small sample size, these numbers could not be broken out by demographics. Next slide. More than half of participants reported at the time they completed the course that they were vaccinated against COVID-19. Across racial and ethnic groups, the percentages were 55% for non-Hispanic Black participants, 58.6% for non-Hispanic white participants, and 55.3% for Hispanic participants. Numbers were too small to provide percentages for other racial and ethnic groups. Next slide. Upon starting the course, participants were asked which 2 sources they trusted the most for receiving information about the COVID-19 vaccine. The most common source reported by 85.4% was their doctor, nurse, or other healthcare provider. The second most common source was CDC website or reports, but this was reported by fewer than 1/3 of participants. So I want to emphasize that you all are the most trusted source of information, so you truly can make a difference. Next slide. This slide lists reasons why participants who hadn't been vaccinated against COVID-19 reported not getting the vaccine. So participants could have selected more than one answer to this question. You can glance over this as I pause for a moment, but I do want to call attention to the fact that roughly 97% reported concern for possible side effects to either their self or their baby. So I want to emphasize that all of these concerns can be mitigated with proper education. Next slide. These are additional, less frequently selected reasons. I'd like to call attention to only 5.7% reporting. It was due to their partner support person not being supportive of getting the vaccine, which might be contrary to what some of us thought. Next slide. Upon completing the course, participants were asked about things that a doctor, nurse, or other healthcare worker may have done. Participants could select more than one answer. More than 3 in 4 participants, or 79%, reported that a healthcare worker had talked with them about getting the COVID-19 vaccine, which unfortunately means that nearly 1 in 4 participants had not had a healthcare worker talk with them about getting the vaccine. About 41% reported being recommended to get the vaccine, and only 1 in 4 reported being offered the vaccine by a healthcare worker. 1 in 10 reported being referred to another place to get the COVID-19 vaccine. So, whoops, I think we're off by a slide. Sorry about that.
Forward, Stephanie, or back?
Let me see which slide. I'm on slide 34.
My slide never
Okay.
don't conflict with yours.
Oh gosh, sorry about that. On this slide, okay, if you want to go ahead and advance, and I'm sorry if I missed something there. Gosh, we still seem to be off. Okay, can you go back?
Sure.
Sorry about that.
So,
There we go. Rope
one
right
more?
back where, yeah.
Okay.
Oh, I had a double layer there. You were okay. I missed that first one. You want to go back 1 click? Sorry about that. Okay, so good news is 3 and 4 were, let's see, talked about it, but unfortunately that meant that nearly 1 in 4 had not been talked to. Apologies for that. So overall, the bad news is that we missed an opportunity for 1 in 4. All right. Now let's see. Sorry, I got to get my slides right here. Here we go. Okay, so as mentioned previously, 79% of participants reported at the end of the course that a healthcare worker had talked with them about getting the COVID vaccine. By race and ethnicity, the percentages were lowest for non-Hispanic Black participants and highest for Hispanic participants. I think we are still off. You want to go ahead, Juan? Go ahead.
Okay.
Yeah. Oh, I know what's happening. Sorry about that. I have a couple slides hidden on my end to get through this more quickly, and I missed them. So, can you go back one so I can talk to that? Sorry about that. Okay, my apologies. Participants were then asked the same question, but about the COVID-19 vaccine booster. Less than half of participants reported that a healthcare worker had talked with them about the booster. Only around 1 in 4 had the booster recommended to them. So again, want to emphasize that only around 1 in 10 were offered the booster by a healthcare worker. Notably, more than 1 in 4 participants reported that they were not vaccinated against COVID-19, and so therefore they were not eligible for the booster. So we need to take that into consideration. Okay, so we will move on now to the key takeaways and opportunities. In closing, I'd like to take just a few moments to note these takeaways and opportunities. Next slide. So generally, and some of this Sarah has kind of spoke to from the broader perspective in the state, but generally there's poor vaccine uptake, which we saw consistently with our population as well. Most vaccinations are administered after delivery. COVID-19 infected pregnant persons were nearly 3 times as likely to experience a stillbirth and significantly more likely to be diagnosed with comorbidities. So again, just a takeaway from what Sarah had mentioned earlier. We know from Kansas maternal mortality data that comorbidities have a definite impact on maternal morbidity and mortality. And I also want to remind, if Sarah's mentioned earlier, that this mirrors national data where it is largely the unvaccinated population who were infected with COVID-19 in pregnancy. So the last takeaway here is healthcare providers are the most trusted source of COVID-19 vaccine information. So I'd really just like to drive home that point, that if we can focus efforts on vaccination prior to and during pregnancy, we could have a huge impact. We have some areas of real opportunity here, particularly around COVID-19 vaccination. Next slide. So those opportunities are to educate about the safety of the COVID-19 vaccine. Again, safety was their #1 concern and reason for not getting it. Promote the vaccine and offer administration of the vaccine, or make a warm referral if your agency entity does not provide the vaccine. Healthcare, while vaccination before and during pregnancy is most ideal, vaccination after pregnancy is still important if moms did not receive vaccines before or during pregnancy. However, moms will not get the protective antibodies immediately if they wait to get vaccinated until after birth. So again, that push for during pregnancy, but recognizing you all in that birth or postpartum phase have opportunity as well. Next slide. So I'd like to take a moment. I know we're running close to being out of time here, but I'd like to take a moment for you to unmute or share in your chat. What data points resonated with you all? What other opportunities do you see? And what is one thing you can do or change in your organization or with your practice that could have an impact? And we'll just pause here for a moment if anyone wants to share anything in the chat or unmute and share. And then I just have 2 quick resources to share before I finish up. So again, was there anything that really resonated with you? Anything that shocked you? Was it, yeah, the rate of stillbirths? And again, you may need to digest and sit on some of this data afterwards. Educating staff members who are more likely not to offer the vaccines, absolutely. Whether that's has to do with personal beliefs themselves, biases, that kind of thing. I think in general, there's a belief that we're over the pandemic. What's the need? But as you all know, COVID's still out there, and there's absolutely still a need for this. Sarah, do you see the question in the chat? It says, I'm curious if the rate of stillbirths is trending similar to other states. There's a couple questions about that.
Yeah, and that is a great question. Unfortunately, I can't speak to exactly what other states are seeing in their own analyses, but I know that CDC did, they published a number of publications using COVID-19 data during pregnancy, and they did, and that, let me just say, that analysis that they did incorporated data from a number of states. So what they were seeing across the board was pretty consistent with what we saw here in Kansas with regards to stillbirths. So I can't speak to specifics, but I know that it is a wider issue outside of Kansas that has been well documented. And I encourage anyone who wants to know more information or read some more publications that CDC has put out on this subject, go to their SETNet webpage. It stands for Surveillance of Emerging Threats to Mothers and Babies Network. And there's a lot of good stuff on there. And I believe I put that link on my resources slide, so you should have it.
Thank you, Sarah. And I believe it's linked in our toolkit as well, which I'll show here in just a couple of slides. So you want to go ahead to the next slide. Thank you. So this is a resource. It's the CDC Foundation's recently released, like more in a little earlier in the fall, their Pregnant and Protected campaign. So you can see there on the slide, there's lots of different resources for use to promote vaccination, especially during pregnancy. There's social media campaign posters, flyers, all kinds of clinical resources as well there. So definitely check that out. The QR code for access to the campaign is here on the slide, and Tiffany will drop the Campaign at a Glance PDF link in the chat for your review, which includes links to the campaign and its resources. Next slide. And then also those resources, and again, I believe some of the data and publications that Sarah mentioned are linked in our toolkit. So just wanted to remind you that there are COVID-19 resources under the KDHE MCH Integration Toolkits webpage. They've all been updated very recently. Actually, I made several updates just last week, and I did check they're not posted yet. So maybe make a reminder on your calendar to revisit this web page next week, or by the end of this week, those should be posted. Everything with those updates in the toolkits, the resources are really relevant during our current post-pandemic state of continued awareness and guidance. And that is it for my piece.
With a minute to spare. Great job, guys. Hey, Sarah and Stephanie, you win for most efficient presentation of the year. I would just like to say vaccinations and conversation of all the things that are offered, that are reviewed, that are there's such an expanse and things are growing so fast that it's okay to be overwhelmed by this conversation and to go, I don't even know how to educate my patients. That's why the resources are there. So when Tiffany sends it out to you all, check those resources out, send it out to your staff, share it with your colleagues, and don't hesitate, again, to reach back out. You've got a wealth of knowledge in that presentation for sure. We're going to let you guys go a little bit early. Again, Tiffany will send this out, including the PowerPoint and recording very soon. And again, a huge thank you to Stephanie and Sarah for a really important deep dive today. Thank you. Have a good day, guys.
Thanks for having us, and thanks for listening, everyone.
Absolutely. Thank you.